Hello everyone, my name is Ijeoma Mlemchukwu. The topic of my project is depression screening in obese patients to increase early detection and referral. This is a project submitted to the Faculty of School of Nursing of Maryville University in partial fulfillment of the requirements for the degree of Doctor of Nursing Practice. Phenomenon of interest. Obesity has become a significant health concern in the United States and across the globe. In the United States, the prevalence of obesity has significantly increased over the last 20 years from 15% to 30.9%. This significant rise in the rate of obese cases has been associated with decreased physical activity and changes in dietary practices. Obesity and depression are often co-occurring conditions with a prevalence of 40% and 21% respectively in the United States. Evidence from Jokela in 2023 denoted that 55% of obese patients suffer from depression. Patients who suffer from obesity and depression tend to experience poorer quality of life. Background. Obesity and depression are bidirectionally related as they are influenced by the same biological process. Depression changes neuroendocrine system which can result in unhealthy eating habits such as overeating which can lead to obesity. Depression limits patients with obesity from engaging in self-care practices, thereby exacerbating weight gain. This bidirectional relationship between depression and obesity demonstrates the need to implement integrated intervention that addresses patients' physical needs and emotional well-being. This bidirectional relationship between depression and obesity also present a need for there to be a depression screening facilities to help with early identification and treatment of this disorder. The PHQ-9 questionnaire offers a standardized tool for depression screening in primary care settings. Project purpose and PCAT question. The purpose of the project was to implement the PHQ-9 questionnaire to address depression screening. The goal was to determine whether implementing the PHQ-9 tool will improve depression screening and referral rate among adults with obesity. The following PCAT questions was developed to guide the project. Among obese adult patients in primary care clinic P, does implementing the PHQ-9 I compared to usual practice C impact depression screening and referral rate in 10 weeks? Significance of project. By providing training on the PHQ-9 tool, nurses will gain confidence and competence in screening for depression, ensuring patients receive comprehensive care. Nurses' ability to screen for depression will lead to increased detection and timely referral for treatment, addressing a critical gap in patient care. Advanced practice nurses can bridge gaps in primary care by incorporating evidence-based screening practices, ensuring at-risk patients are identified and supported. The use of the standardized tools like PHQ-9 enables advanced practice nurses to detect depression earlier, leading to more effective interventions and better patient outcome. Screening tools ensure equitable access to mental health care, addressing disparity often faced by vulnerable populations such as obese adults. Timely intervention prevents escalation of depression symptoms, enabling patients to lead healthier, more fulfilling lives. Theoretical framework. The selected theoretical framework for this study is Havelock theory of plan change. The theory is made up of 6 steps, which are building relationships, identifying the issues, gathering information, selecting solutions, implementing and institutionalizing change. Rationale for selecting this framework. This theory is structured and facilitates stakeholders' engagement. Havelock focuses on recognizing problems and fostering readiness among stakeholders and supports the introduction of sensitive interventions like depression screening. Application of the Havelock's theory of plan change to PHQ-9 integration. The first step entailed educating stakeholders about the purpose and benefits of the PHQ-9 and build trust and foster support for its implementation. Next step will be an assessment that was conducted to determine the present state of depression screening at the facility that we used. Then the next step was implementation. The implementation team ensured that there is adequate training materials and technological assistance. Next, a pilot phase will be implemented to collect feedback and improve on the intervention before it is implemented on a wider scale. Finally, the change was implemented and built the PHQ-9 questionnaire into routine workflow with clear policies, ensuring long-term sustainability and consistent use. Review of literature used. PHQ-9 has been found effective in enhancing depression screening. A study by Ford et al. In 2020 found that implementing the PHQ-9 intervention improved depression screening from 15% to 70%. Prior scholars have also found that PHQ-9 questionnaire is a valid tool and is effective instrument for depression screening. Other scholars have also established that the PHQ-9 tool is accessible, practical, and easy to use. Impact on referral rates. By effectively addressing depressive symptoms, the PHQ-9 questionnaire aids in identifying individuals with depressive symptoms which may otherwise be undiagnosed. In turn, several scholars have found the PHQ-9 effective in enhancing patient referral rates. Association between depression and obesity. Obesity caused pathophysiological changes such as changes in neurotransmitters and increased inflammation, which are essential for mood regulation. Both conditions have also been associated with poor eating habits. Furthermore, several studies have also confirmed that individuals diagnosed with obesity have a higher likelihood of developing depression. Literature critique. Strength of the literature's use. The articles included in the review provided relevant, valid information to support the effective implementation of the PHQ-9 tool in primary care settings. Many of the studies were primary sources, offering direct evidence of the PHQ-9 impact on improving depression screening and referral rates. Some weaknesses of literature use are non-randomized sampling in studies like BB and UTLE limited the ability to generalize findings across broader populations. Volunteer bias was evident in studies like Calif 2021, where digital technology users differed from non-digital participants, affecting the outcome. Also, the inclusion of studies with varied methodology quality, such as Eldan in 2018, reduced the generalizability of the findings. Gaps in the literature. Limited research on obese patients. While there are numerous studies on PHQ-9 primary care clinic, there is a significant lack of research focusing on its implementation for obese patients. This gap highlights the need for targeted studies in this demography to improve outcomes. Limitation. Studies in specific healthcare settings. Many studies were conducted in specialized facilities like academic clinics, making it difficult to generalize findings to other healthcare environments. Also, low sample sizes were limitations. Several studies involved small participant groups, which weakened the statistical power and reliability of the conclusion. For example, subgroup analysis in some studies yielded insufficient data for robust conclusion. Methodology. The project involved a quality improvement methodology which entailed using a pre and post intervention design to determine the impact of the evidence based intervention on clinical outcomes. The project measured the rate of depression screening and referral before and after the intervention was implemented. The project setting was a primary care clinic located in Southern California, United States, that treats close to 500 patients monthly. The healthcare facility attends to patients from diverse racial backgrounds, including African Americans, Asians, whites, and Hispanics. Adult obese patients at the clinic rarely undergo depression screening. Data collection. The sampling approach for the project was convenience sampling. The inclusion criteria were adults aged 18 years and above who are clinically diagnosed with overweight or obesity and currently being treated at the clinic. The exclusion criteria were patients below 18 years, patients who are not being treated at the clinic, and patients who have not been diagnosed with overweight or obesity. Instruments used. The pre and post intervention depression screening and referral data was collected from the clinic's electronic health record. The data was then recorded on a Microsoft Excel sheet. The Excel sheet was used to record the number of adult obese patients screened for depression both before and after the implementation of the PHQ-9 questionnaire. Healthcare staff at the facilities were trained on how to use the PHQ intervention and how to track and record this information. Data analysis. Descriptive statistics. The study used descriptive statistics to summarize the characteristics of the sample using percentages and frequencies. Inferential statistics. This was used in determining the impact of implementing PHQ-9 tool on depression screening and referral rates. McNemer test. This is a non-parametric test that was conducted to analyze paired nominal data to determine whether there are differences in dependable variable. Data evaluation. Evaluation of the data was conducted using comparative analysis between the pre and post intervention. This was by comparing the number of patients screened for depression, the number of positive screening, and the number of referrals made for further mental health services. Demographic of findings. Here, this table here shows the demographic of my findings, which shows that out of my participants, 112 of them were male, 98 were female, and 23 of them were between the ages of 18 and 30, 36 were between the ages of 30 and 40, while 55% of them are between 40 and 50 years old. 96% of the participants, 96 of the participants were above 50 years old. Outcome of intervention. Pre-intervention findings. Of 210 patients, 139 had not been screened for depression or referred for any further evaluation. 71 patients were screened for depression, with 30 of them, which is 42% of the 71, not referred, and 41 of them were referred for further evaluation. The finding shows that 169 patients, that's 81%, were not referred, and 41 patients were referred. Findings from post-intervention. From the post-intervention demonstrated that out of the 210 patients, 93 patients were not 93 patients were not screened for depression, and none of them were referred for further assessment, demonstrating 100% of the non-screened group. Of 117 patients screened, 9% were not referred, while 91% were referred for further assessment. The result shows that 104 patients, which is 50% of the population, was referred, and 106, which was 50% of the population, were not referred, and 106 of the patients, which is 51% of the population, were referred. Comparison of findings. Pre-intervention data. Before the intervention, a significant portion of patients, 66%, were not screened for depression, indicating a gap in early identification. Of those who were screened, 42% did not receive a referral for further depression care, suggesting a need for improved follow-up and referral protocols. The overall referral rate was very low at only 20%, indicating inadequate linkage to depression management services, which could impact patient outcomes. Now, post data intervention. After the intervention, the proportion of non screened patients dropped to 44%, showing a positive impact in increasing depression screening coverage. Among the patients who were screened, the percentage that were not referred decreased dramatically from 52% to 9%, showing that the intervention improved referral practices. The total referral rate increased substantially to 51%, highlighting the effectiveness of implementing the PHQ-9 tool in facilities for both screening and appropriate referrals. Key outcome. These results clearly demonstrate that the introduction of the PHQ-9 questionnaire improved both the rate of depression screening and the rate of referral to appropriate care. This improvement can lead to better patient outcomes, particularly for adult patients with obesity who may have unaddressed mental health needs in a primary care setting. Discussion. The implementation of the PHQ-9 tool led to a significant increase in both depression screening and referral rates, aligning with similar findings from past studies such as Ford et al. In 2020. The PHQ-9 provides standardized objective framework for screening depression, reducing variability in practices, and ensuring consistent identification of depressive symptoms across all patients. Management support and the availability of established EHR system facilitated seamless integration of the PHQ-9 tool, ensuring adequate data collection, easy access, and consistent documentation of screening and referral. The PHQ-9 addressed time constraints in primary care by offering a quick, efficient depression screening method, ensuring that mental health assessments could be integrated into busy clinic workflows without overwhelming providers. Limitations. One limitation for the study pertained to potential selection bias, as the study applied convenience sampling from patients being treated for obesity at the facility. Another limitation pertains to the dependence on clinical staff for screening, which may introduce variability in terms of how the tool is administered and also how data is collected. Finally, the pre and post implementation design cannot control for all external factors that may have influenced depression screening and referral rate, such as seasonal variations. Post implementation insights. The finding shows that systemic depression screening using the PHQ-9 can lead to better identification of patients needing mental health services and improve the overall quality of care. The clinic staff training ensured accurate administration of PHQ-9 and its integration into routine assessments. Initial staff resistance posed a challenge, which in turn required ongoing education to reinforce the importance of depression screening to the staff. The clinic management support was crucial for the successful implementation of the sustainability of PHQ-9 intervention. Effective use of the electronic health record and maintaining data accuracy were essential to the success of the intervention. Implications. Practice implication. Incorporating PHQ-9 as a routine part of patient assessment to ensure consistent depression screening. Streamlining data collection and analysis by automating the recording of PHQ-9 results. This will enhance data accuracy, reduce administrative burden, and support real-time monitoring, ultimately contributing to continuous quality improvement. Create training programs to ensure healthcare providers understand how to properly administer and interpret the PHQ-9 questionnaire. Implications on future research. Future research should explore the long-term impact of integrating the PHQ-9 into routine practice, including patient outcome beyond the initial intervention period. Investigate the effectiveness of tailored training programs to improve provider proficiency in using this tool. Policy implications. Policymakers should incentivize the use of validated tools like the PHQ-9 through resources for training, electronic health record integration, and quality improvement initiatives. Policymakers should adjust reimbursement policies to prioritize depression screening and management in primary care. In conclusion, findings from the project support the integration of PHQ-9 tool as part of screening routine during patients' visits. This involves providing ongoing training and education for healthcare providers on the administration of the and interpretation of PHQ-9. It is also essential to foster a culture that values mental health and promote interdisciplinary collaboration for effective depression care. To ensure sustainability of the project, it is essential for the PHQ-9 tool to be integrated as part of the standard operating procedure and also providing staff with the training needed to address resistance. There is also a need to evaluate the long-term sustainability of implementing the PHQ-9 and to explore tailored training programs aimed at optimizing healthcare providers' proficiency in using the tool. The dissemination plan will entail the following strategies: sharing the findings with the facility management, publishing the study in a peer-reviewed journal, and presenting the research findings to conferences and workplaces. And that concludes my presentation. Thank you everyone for your time, and thank you for listening.